Okay, good morning. I'm very excited to announce Shiva Bidar Sielaff as our Grand Round speaker this morning. Shiva Bidar Sielaff is the UW-Madison School of Medicine and Public Health Associate Dean for Diversity and Equity Transformation and UW Health Vice President for Diversity, Equity, and Inclusion. She leads a comprehensive effort to embed equity, diversity, inclusion, and anti-racism as imperatives in the UW Health and SMPH missions. She facilitates alignment and progress in areas such as learning and education, faculty and staff support, equity in systems, policies and process, support for basic science departments and their training programs, and programmatic accountability. She completed her undergraduate degree in Belgium, followed by a Master's of Arts in International Policy Studies at Monterey Institute of International Studies in California. In 2015, she earned a certificate in the diversity management from Georgetown University. In 1997, she first joined the health system to establish UW Health's Medical Interpretation Services program. She became Director of Community Partnerships for UW Health and then UW Health Chief Diversity Officer. In 2020, her health system role was elevated to a Vice President position. Shiva Bidar Sielaff is an established leader and effective champion for advancing equity and diversity at the individual, organizational, and community levels. She has served as an alder on the City of Madison Common Council and has experience serving on the Governor's Health Equity Council as a co-chair of the Latino Health Council of Dane County. And as a member of the Madison Community Foundation Board, her many accolades include being named the 2019-2020 UW-Madison Outstanding Woman of Color. We really appreciate your time and expertise this morning, and I'm looking forward to this wonderful presentation. So I'm hoping to turn this over to Shiva now.
Thank you. Thank you so much. I hope you can hear me okay.
Yes, I think I can hear you well.
Perfect. Good morning, everybody. Thank you for such a kind introduction. I'm going to make sure we have our slideshow up. It's really a great pleasure to join you this morning to talk about one of my favorite topics, and one that, as background, is really very dear to my heart. As was mentioned, I actually started our language access program at UW Health, or UW Hospital and Clinics, as it was called then, many years ago, and was also the first Spanish interpreter on staff at UW Hospital and Clinics. So it's something that that really means a lot to me to have seen the growth of our language access program. So I want to spend a bit of time today to talk to you about how to make sure you integrate language access into your daily practice. I want to also mention and give a shout out to my great colleague, Diana Anillo Manotas, who is our manager of interpreter services for UW Health, and who's joining me this morning, and will also be available to answer any specific questions that may come up at the end of my presentation. And feel free during the presentation, if you're joining us virtually, to add any questions that you have into the chat too, so we can go back and look at the chat questions. So I want to spend some time this morning, one, explaining key definitions and our legal and regulatory requirements related to language access, examine some of the best practices for language access, and talk about how we can maximize the appropriate use of interpreters in your daily practice. So first, let's just do some level setting around demographics and the population that we're serving in language access. So about almost 14% of US residents are foreign born, meaning immigrants, as that's the definition of foreign born. As you know, in most countries around the world, English is not the primary language, which means the majority of these foreign-born immigrants speak a language other than English as their primary language or their native language. About 21.5% of US residents that are 5 years or older speak a language other than English at home. That's 66 million individuals. Again, meaning that their language of comfort and their primary language at home is a language other than English. And then very much more specifically around those who are considered limited English proficiency individuals, that's about 8% of the US residents 5 years and older. And then for that group of limited English proficient individuals, we also know that across the country, as here in Wisconsin and in Dane County, a large portion of them are Spanish speakers. The reason that I wanted to mention languages spoken at home and language of comfort is because although we look at limited English proficiency as kind of our standard of the individuals for whom we provide interpreter services, we also know day in and day out that when individuals are at the time of stress, when they are trying to really relate information that is very specific, that they want to use words, for example, of description of pain and other things, that people are oftentimes more comfortable in their native language or their primary language, even though they may speak English at a level that allows them to interact on a daily basis in other ways. So again, we want to make sure that we're certainly providing interpreter services for those who are limited English proficient, but we want to also make sure that we're opening up the provision of language access to anybody at any point in time, maybe during their care, in which they feel that having an interpreter would allow them to feel more at ease and communicate more effectively. Now, some data around Wisconsin in our population that is limited English proficient. If you look at our data in Wisconsin, again, Spanish is the largest language that we serve, and our largest population of limited English proficient individual, followed by Hmong Chinese as the next languages. So again, this gives you a good picture of what Wisconsin looks like compared to also the national data. Now I want to switch gears a bit and talk about the legal and regulatory requirements to provide language access. So although, I always think that communications is really key to the provision of good care and patient-centered care, we also have some legal and regulatory requirements that do require from all health systems and healthcare facilities to provide language access. So the first legal requirement comes from the Title VI of the Civil Rights Act of 1964. I realize that oftentimes people do not think about the Civil Rights of 1964 as it pertains to language access, but actually the Civil Rights of 1964 is what set the standard for legal requirements for language access, because it says that no person in this country should be discriminated on the basis of race, color, and or national origin from any kind of benefits or services that receive federal financial assistance. So national origin is the part of the Civil Rights Act of 1964 that then is interpreted as meaning that people who speak a language other than English do so because of their national origin, because they come from a country where English was not their primary language, and that they cannot be discriminated against in any kind of service that received federal financial assistance. So as you can imagine, academic health centers for sure fall under this category, since we receive federal funding in many different ways, including accepting patients who have Medicaid and Medicare, which is a form of federal benefit. So this means that all our patients, our entire patient population, falls under the requirement to provide language access. The next legal requirement is the Americans with Disabilities Act of 1990. This is the legal requirement that covers our deaf and hard of hearing patients and their right to having a qualified sign language interpreter. I have to say that this is one that's often better known, but this is kudos to the deaf and hard of hearing community for the level of knowledge and advocacy within their own community to really understand their right to access a qualified sign language interpreter. Then we have some regulatory requirements, and the main one is through the Joint Commission. The Joint Commission has a number of standards that are around language access that are a subset of the overall standard that says that we have to have a way of providing effective communication for each patient that we serve. And then over the years, Joint Commission has become much more detailed in their requirements for language access, including making sure that, for example, we have an ability to assess and know the qualification of interpreters that are providing interpreter service, as well as the qualifications of those providers that are providing bilingual services or providing services directly in a language other than English to patients. So the Joint Commission requires us actually to have a way to document, to assess and document the qualifications of, again, individuals who are interpreters within our health system and individuals who are considered to be bilingual. And I'll come back to how we do that within UW Health later in the presentation. I was part of the group that set the standards for the Joint Commission a number of years back. So again, we are an organization that is fortunate to really have invested the resources to make sure that we meet those standards for Joint Commission. Last but not least, at UW Health, we have a policy. The policy is really a reflection of our both legal and regulatory requirement, but more specifically, it really sets the stage for how is it that we're going to operationalize those regulatory and legal requirements. So our policy really very specifically outlines the way that you request an interpreter, and the way that we document the need for interpreter services within Epic or HealthLink. When is it that it is appropriate to make sure that we are using an interpreter? What are the things that are not appropriate to do, such as use of friends or family members? So again, the policy really goes into a lot more detail in how we can make sure that we provide appropriate language access. So some key definitions that are in our policy, but are definitions that are also based on the national requirements and standards for language access. One, as you have seen, I've used the word limited English proficient individuals. This is a really important term to use because one is the term that's used by the Office of Civil Rights at the national level and at the state level. It also is a term that really speaks to the fact that we want to provide interpreter services to anybody who is not able to interact effectively or understand effectively the communication that's happening within healthcare. It is a very different term than non-English speaker. And the reason we don't use non-English speaker is because we actually have very few people that could qualify as non-English speaker, like they don't speak any English at all. Most of our patients that are limited English proficient speak English at differing levels, some very, very limited, some limited, and some relatively limited. But we want to make sure that that the standard is that they can interact effectively back and forth in their communication with the healthcare providers. Qualified interpreter, again, we don't use just the word interpreter. We say qualified interpreter because what has happened historically is people have called interpreter anybody that they thought was acting in potentially a role of an interpreter. A qualified interpreter is actually a medical interpreter who's a specially trained professional who has been assessed for their professional skills. At UW Health, and also I would say at Unity Point Health Meritor, since I know some of you, of course, also practice at UW Unity Point Health Meritor. Qualified interpreters in our setting for our in-person interpreters means that they are nationally certified medical interpreter. We only use nationally certified medical interpreters for our in-person interpreters. And then bilingual staff or staff and providers who have demonstrated proficiency in a language other than English. And again, the demonstrated proficiency is really important. And again, I will speak to how we do assess that proficiency at UW Health. So now let's delve into some of the more specific information about how you have to make sure that you integrate language access into your daily practice. So the first question that usually comes up is, do I need an interpreter? How do I know I need an interpreter? So one interpreter need is shown in the patient's profile in HealthLink. So we make sure that we capture a preferred language or interpreter needed, as we call that field, within the demographic profile of our patients. And we do this very, very accurately. Our admissions and our staff that do our registration are very well trained in doing this. So I would say in a very large majority of the cases, over kind of 98% of the cases, we have good and accurate information about the language that the patient prefers to receive their care in. We also want to make sure that if that is not the case and the patient, so for example, the patient, Shiva, doesn't have Spanish as her preferred language, but at one appointment or during a certain encounter, I request an interpreter, we still want to make sure that we respond to that request. It may be, for example, a case in which, given that particular situation and the stress that I'm in, I would prefer to have an interpreter, but usually I don't. Or it may be that the family member that's accompanying me to the particular appointment would like to have an interpreter because they would like to better understand information. One area specifically where we see this is in, again, when we look at GYN oncology and, the times in which there is either a treatment plan that's being shared or the news about diagnosis that patients that, again, usually may be totally fine and having their care in English may bring a family member that is limited English proficient. And we want to make sure, again, that we provide an interpreter for the family member. The providers, again, if I prefer to communicate in my native language. And the last one is if you as the physician or think that it would be best to have an interpreter. So again, sometimes patients, just because they don't feel that they should be asking for an interpreter, or they're bringing a family member or a friend that they think could serve as an interpreter, are not requesting the interpreter. Or they feel that English is at a level that allows them to communicate well enough, but you are realizing as a physician that there is difficulty in communication and that there is not effective communication, you can request an interpreter. And we get questions often about, well, would this be, the patient would feel like this is rude to them? Would they feel offended? How would I do this? And what we found that if you do this in an approach that is really a patient-centered approach by telling the patient the following phrase, I will just give it to you. We have interpreters, qualified medical interpreters as part of our healthcare team that are available at no cost to you. And I feel that to make sure that you receive the best care possible, it may be most helpful for us to have an interpreter. And again, it's available right away and there is no cost to you. The patients, usually when they hear that, they are completely fine having an interpreter because they've been worried about, is there going to be additional costs? Is it going to be additional delay if I request an interpreter? Maybe also feeling a bit shy about asking for an interpreter. So again, if you say those things, that would be great. If there is a family member involved who's acting as an interpreter, you can also say, and that way we can have, let's say it's the daughter that's acting as interpreter, we can have your daughter fully participate in the conversation and the care, not having to worry about interpreting. Again, those are things that we usually seem to be very effective in making sure that the family understands that providing an interpreter is part of us providing the best care possible for them. Uh-oh, my computer decided, okay, here it is. So now at UW Health, who is authorized to be an interpreter? Or who's authorized, I should say, to provide language access first. So first, qualified bilingual staff. Just, we want to be clear that for us, the important thing is to provide language access. We're not trying to drum up business for medical interpreters. I can guarantee you our medical interpreters are super busy all day. So if there is a qualified bilingual staff provider that's able to provide what we call language concordant care, so speaking the same language as the patient, just like you would do with an English-speaking patient, that is great and outstanding. We are extremely supportive of that. The more bilingual providers we have, the better off we are, and the more linguistically concordant care we are providing. But we want to make sure that qualified bilingual staff are indeed qualified, meaning that they have demonstrated proficiency in the non-English language by either passing an over-the-phone proficiency test. So we use a nationally recognized organization called ALTA to do this proficiency test. It's about a 20 to 30-minute test that's delivered over the phone. And then we receive their results, and based on, again, their demonstrated high level of proficiency, we can deem somebody qualified to be a bilingual provider. Or alternatively, if you have graduated from a college or post-secondary in a country where the non-English language is spoken, and can send us an email saying, you know, I graduated from medical school in Lebanon and I speak Arabic, then that is our documentation that allows us to deem you as a qualified bilingual provider. Once we have deemed somebody a qualified bilingual provider, we also let the HealthLink team know, and that gets added into their profile as providers, so that when there is a match between the patient's language and that physician or provider's language, we're not providing an interpreter. So for example, if we have a physician who is Spanish speaking, and we put that in their provider profile, then when there is a Spanish speaking patient scheduled in outpatient or ambulatory with that provider, we can see that there is a match between the provider and the patient. Then the next way that we provide language access is nationally certified medical interpreters. And nationally certified medical interpreters are either staff interpreters or contract interpreters. So those are in-person interpreters that we can schedule specifically both for inpatient needs and ambulatory needs. We do have a national certification for both spoken language interpreters and for our sign language interpreters. And again, we require of all of our interpreters that are going to be interpreting in person to be nationally certified. This is really a gold standard in the field of language access. We're one of the only areas in the country that requires this level of demonstration of skills from our interpreters. And then we have remote interpreter services, which is video and phone that we provide through a vendor. And so it's again available by dialing through the phone an 800 number or through video iPads. So some things that interpreters are able to do and some things that they're not able to do. So one is interpreters are, again, because they are nationally qualified, they really have training that really allows them to understand medical terminology, to be able to interpret accurately medical terminology and concepts. And they're also familiar with the US healthcare culture and the culture of the limited English proficient patient, so that they can interpret accurately across languages. I always say that language is it's really a reflection of culture, so it would be impossible to interpret accurately if you didn't understand the meaning, the true meaning and of concepts in a culture. A quick word that I use as an example for this is the word referral. The word referral is a US healthcare culture word. It doesn't exist anywhere else. And when we say you need a referral, what we mean in the US healthcare system is you need an authorization, usually from your primary care physician, to see a specialty care physician so that your insurance company can cover the cost of the visit with the specialty care physician. So I said all of that after I said one word in English. So I use that example to say sometimes we hear that interpreters went on for a long time after you only use one word. And that's because sometimes we do have to actually explain the meaning of that word because there is not a direct meaning to meaning if we don't actually explain it. And the word referral was a very good example of how much longer it may take to explain that what you just said was authorization from primary care to see specialty care so that your insurance company can cover the costs of your visit. Family members are not interpreters by definition. They absolutely are not, and friends are not either. They're good family members and friends if they're accompanying that person usually to their visits. But your family members and friends, just like mine, have a lot of opinions about your life, I'm sure. And so it really is actually kind of the opposite of an interpreter. Interpreters have a role that is being neutral, that is a role of really interpreting everything that's being said. Friends and family members usually are going to insert their own opinions, edit information. They're not trained, so they're not going to be able to remain accurate. And there are many studies that shows that the role of friends and family members in interpreting really leads to huge issues in miscommunication. In addition, it puts the family members and friends in a really awkward position. For example, oftentimes we know that minor children, children of immigrant parents, are put in the position of having to interpret in very, very difficult situations. For example, we have cases in which a minor child of 10 years has been used during after an ultrasound to give the results of the ultrasound by having to tell the pregnant mom that there has been a problem with the pregnancy and potential fetal demise. So you do not want to have obviously a child be put in that position, and that creates a lot of trauma. So children should be left to be the children they are, appropriately in their role, and not used as interpreters, including teenagers. So a couple other things that interpreters do is, in addition to, of course, accurately interpreting everything, is ask for clarification if there is confusion. So sometimes, again, the language that's used or the words that are used may need some clarification, whether it is because maybe the physician used a medical term that was very complex and the interpreter wasn't sure if they understood correctly that medical term. They may ask again in a very transparent way, and it goes like, as the interpreter, can I ask for clarification? You just use this term. Can you use maybe another term, or I'm not familiar with that term. Could you explain it in another way so I can interpret it accurately? Same with the limited English speaker. We can ask for clarification. Again, for example, in Spanish, we have some variation in the words and terms that are used across Spanish-speaking countries. So if one of our Spanish interpreters is not understanding the particular localized term that's being used by a patient, we may say, can you clarify what you mean by that term so that I'm sure to interpret it correctly. We may provide a cultural framework if we're seeing that there is a misunderstanding between the provider and the limited English proficient individual, but we will do that in a very quick way and do it quickly. So we want to also make sure, I'm going to go quickly through this and get us to the things that we should avoid, but we want to make sure that the interpreter is sitting in a way that allows you to communicate directly with the patient and not be looking at the interpreter. So making sure that either the interpreter is, if you are in an inpatient setting, for example, you're kind of standing behind you. If it's in a delivery situation, usually maybe standing behind the head of the patient. So that, again, you're kind of communicating and looking at the patient as much as possible. If it's in an ambulatory setting, in an exam room, again, making sure that the interpreter is sitting kind of next to the patient and that you're looking at the patient. If you're at the desk, if you're doing a physical exam of the patient, maybe the interpreter being either behind you, one step behind you, or behind the patient's kind of head, to be able to, again, allow for good communication and verbal connection between you and the patient. What we want to avoid with language access and with speaking with patient across languages is highly technical speech and jargon, which I always say should be avoided with all patients at all times. But one thing we realize is that sometimes there is a perception that interpreters will actually simplify the language, and that if you use like highly technical medical terms, that the interpreter will make sure to simplify that language for the patient to understand. And our role is actually not to simplify the language, but to stay within the same register and try to use the same exact words that are being used by the speakers. Idiomatic expressions, metaphors, jokes, those really do not translate well across languages, so it's better to avoid them. My favorite is always comments sometimes about either sports teams that are US kind of based sports, so like American football, and kind of comments that are made as icebreakers about it, or again, some idiomatic expressions or references to things that are very, very culturally based, that again, for most of us immigrants really do not have the same meaning, and it really is very difficult to try to interpret those. Comments that you do not want interpreted, do not make them in front of the interpreter. So sometimes that is a conversation that happens between attendings and residents and fellows right in the room where the interpreter is still present and the patient is there, and there is like turning to each other and started speaking in English because there is a sense that maybe the patient is not going to understand it. So a couple of things about that. One, the patient, as we said, limited English proficient means that people are picking up and understanding some of the words, but then that may really create worry and misunderstanding because they may pick up one word. Like, let's say, for example, you said something about ruling out cancer, and the only word that they understand and hear is cancer. It also puts the interpreter in a difficult position because they're there to interpret everything that's being said. And so when side conversation is happening, it's difficult for the interpreter, one, to keep up with that side conversation. And again, understanding that maybe you're having that side conversation with the intent of not having it interpreted. So again, nothing should be said within the room that you do not want to have interpreted. Do not ask the interpreter for the patient's history or state of mind. We get asked that sometimes because, especially for our staff interpreters, we may have had ongoing visits with that patient, whether it's like an ambulatory or whether it's like the patient is inpatient, and we've had the same interpreter come several times for different rounds for that patient. Even if it's the same interpreter, interpreters really are not the holders of the patient's history or can diagnose really things like depression and other things. I know I was asked as an interpreter sometimes, it's like, hey, do you know if the neuro team already came by and saw the patient? Do you know, if the patient has disclosed any history of, and I would always say, I'm only the interpreter that has interpreted these kind of situations or part of those conversations. Please check the medical record. And then leaving the interpreter in the room alone with the patient, that's not appropriate either. The interpreters would actually want to leave the room, but we sometimes have heard from providers complaints about why is the interpreter leaving the room, why is the interpreter outside in the hallway. And the reason is because if the interpreter stays in the room, there is a lot that can happen that are conversations that the patient shares with the interpreter that are either personal, things that the patient then asks the interpreter not to tell the provider, and we just do not want to put the interpreter in that position. The interpreter is a member of the healthcare team. We don't need to be spending extra kind of social time with the patient waiting in the room. And as you know, sometimes those wait times can be quite long. Again, if you speak a language other than English, we want to make sure that you do so at a level that really allows you to effectively communicate with patients, which is why we have the assessment that we do for proficiency levels. And then my last slide before I open it up to question, and please, for those of you who are joining remotely, you can also tap your questions and I look at the chat as soon as I'm finished here. But the last question that we often get is for written translations. So one, a qualified interpreter is not necessarily a qualified translator. Those are two different set of skills. I would say the best way that I can compare it is that you have some people who are really excellent writers, but who are really not really good speakers. And the opposite, you have people who are amazing speakers and they do not have really great written skills. So that's the difference between interpreter and translator, two different skills, both of them requiring a very high level of knowledge of the non-English language, but really different skills. That is why also interpreters cannot translate information on the fly. Like, hey, here is the after visit summary. Can you just quickly, in the next 10 minutes, just write it all in Spanish? It doesn't happen that quickly. Translation is actually a very sensitive, time-consuming task. There's really a lot involved in really doing accurate translations. So again, our interpreters that come to interpret in person are not qualified to do written translations. They may be able to do some very, very narrow things like dates and times of next appointments, etc. But we ask you, one of the ways that we ask you to work with us on this is that you can actually ask the patient to write some of the key information. Or one thing that we've found to be very useful is tell the patient that they can record the instructions that are given to them verbally on their smartphone if they have one, which most of our patients do. Never use free translation websites. They really provide inaccurate translations. And I know they seem like an easy way to do things, but even for very basic things, Google Translation will get us in a lot of trouble and create some real huge miscommunication at best and patient safety risk at the other end. Using trustworthy sources such as HealthWise, which is the vendor that we use at UW Health, that they have a lot of information available in a number of different languages, and we have checked the accuracy of translation for this vendor. We also certainly have other information that is available at UW Health. We have Health Facts for You, which is our patient education materials that we have translated in Spanish, and there is many of them that are around OBGYN that we have translated into Spanish and are available through UConnect for you to print and give to the patient. And of course, ACOG has also good materials that are available in Spanish. Also, although I would say my experience with the materials from ACOG is their level of literacy is pretty high in the materials. So I would just put that as a caveat. That leads me to being aware of literacy level. Providing written translation does not resolve the literacy levels. And what we see oftentimes is that even when we're providing the material in Spanish, many of our limited English proficient patients are not understanding those materials or may not have the level of literacy in their native language to be able to understand written materials. So not making the assumption that a Spanish speaker has the level of literacy to be able to read materials in Spanish. That's why we have found that actually providing really clear verbal instructions and allowing our patients sometimes to record that on their smartphone has been the most effective way of providing instructions that patients can take with them. UW Health Interpreter Services now, this is what Deanna's and the interpreter team's world looks like. And so we have 8 Spanish medical interpreters that are full-time medical interpreters on staff, 1 sign language medical interpreter, but 60 contract interpreters that cover 23 languages. And then we have our remote interpreter services, which is language learner Pacific interpreters. We have iPads that are available across all our clinics, and also iPads available on the units and that can be checked out for each inpatient during their stay at the at UW hospital or the East Hospital or the main hospital at any time. So, and then you can see we have for Spanish 24/7 coverage with both the staff interpreters and then the after-hour on-call. And then, of course, our remote interpreter services is also available 24/7 on demand. So the 5 things that actually there are 4, which, that's good. I must have had the 5th one in mind when I did this slide, so maybe I'll come back to it. But so no culturally appropriate care without appropriate language access. For me, we often see discussions about, providing culturally appropriate care, cultural humility. And for the patients that are limited English proficient, cultural humility starts with providing language access and making sure that we are not trying to communicate with them by raising our voices, hand gestures, half broken Spanish, but really centering their needs to have appropriate language access. Using qualified medical interpreter is essential. Medical interpreters are part of the medical team and part of the healthcare team, so see them as that. Interpreters are really there to support the development of your relationship with the patient and family. And then we realize that it may take a bit longer and that you need to be a bit more patient when communicating across languages. But at the end of the day, accurate communication is key to a good outcome for our limited English proficient patients. With that, I'm going to stop sharing so that I can see if there are questions in the chat, and I'm happy also to take any questions that you may have. I left a lot of time for a question because I always actually enjoy the actual questions, scenarios, communication across these issues.
This is Katie. I have a question that might be for, I don't know if it's for you or for maybe just others who are in leadership. For patients who require an interpreter, has the health system considered ways to help facilitate that from a provider standpoint, like additional visit time or additional compensation? I'm wondering about those types of things because my experience is my visits usually take significantly longer to do them right, to make sure that you're providing the time to really understand. I'm just wondering if that has been considered as well.
Thank you, Katie. That's a question that actually comes up pretty often. I can say that, there's been conversations around it, but there is really a lot of unintentional potential impacts of making visits longer for limited English proficient patients. So a couple of examples of that is that one, if they have insurance, there is like the billing to the insurance, it changes based on potentially the type of visit and the length of visit. Also for longer visit, it may take, if we assign longer visit, it may take longer for that patient to get in for an appointment. So then, unintentionally, we're potentially providing inequitable access for our limited English proficient patients. So there is just a lot of again, because of how the system overall is built, issues with it. I would say that this is a conversation that also has been had nationally in, around other health system. And there is no health system at this point that I know about that has actually made that decision to increase the length of time of the visit, because again, nobody I think has been able to figure out how to mitigate for the unintended consequences. So that's one, but again, something that comes up pretty often. I would say, one, this is not going to certainly be a perfect answer to your question, but one way that we try to mitigate the potential length is clearly by having qualified interpreters. We know that with use of certified medical interpreters to, again, recording that have been done, that it usually takes 20% longer. So not like double, but about 20% longer for the length of the visit because of the time needed to do interpreting. So, and then you had a question about compensation, and that one, actually, I don't have a particular answer to. Meaning, did you mean compensation for those who are actually bilingual providers, or compensating differently for seeing a larger number of limited English proficient patients?
Yeah, I was kind of thinking about providers who might see a large number of limited English proficiency patients, not in their native language. I'm thinking those providers, if the visits do take longer, that's impactful potentially. But I appreciate the kind of insight that you shared with the kind of first answers, helps to understand that better.
Yeah. Other questions?
I'm going to bring the mic to Dr. Spencer here.
Okay.
Morning, Shiva.
Good morning.
Thanks so much. It's always fun to get your perspectives, and you're just so knowledgeable. It's great. What suggestions might you have for us as clinicians if a patient refuses an interpreter and we think they need one? I've had some scenarios that I've worked through and just want to hear from you best practice approaches.
Great, thank you so much, Ryan. So a couple of suggestions. One is when patients are refusing an interpreter, it's important to really think about why is it that they are refusing an interpreter, right? So I think the first thing that I would say, the suggestion is the why, like, why are you refusing an interpreter? And we hear a couple of different scenarios. One is because they don't think they need it. They think their English is good enough, or they had a bad experience with an interpreter in the past. And I'm going to put with an interpreter, quote unquote, an interpreter in the past, and I'll come back to that. The third one actually is, I have this family member, or, my daughter is great. I don't want to upset my daughter by asking for an interpreter because, I want my amazing daughter who speaks English well here. Sorry, my computer just, so that could be another reason. The way to approach them in essence is, in my opinion, addressing all of it at the same time, because that makes it like a really kind of short explanation to the patient, which is to really address all of the, and the fourth actually reason is cost. They think that it may cost them additional money to have an interpreter, that we will charge them for the interpreter. So I would address it in saying to the patient, I think having an interpreter is a way for us to provide the best care possible. Interpreters are part of our medical team. Again, this addresses the issue of, I've had problems with interpreters in the past. What has often happens in smaller communities is that the patients have had experience with people who played the role of interpreters, came with them, and then broke confidentiality, disclosed information about them in their own small communities. And these weren't medical interpreters, these weren't certified medical interpreters, but they had that role of interpreter, right? So telling them our medical interpreters are part of our healthcare team and they maintain confidentiality just like the rest of the healthcare team. There is no cost to providing you language access. And having an interpreter present does not mean that your family member is not going to be able to be present in the room if you so choose and interact with us during the visit. So usually when we say all of those things, the majority of our patients honestly say, well, okay, now I understand, thank you, then yes. What we often see is the family members may still say no. The family member is just interrupting and saying, no, I told you, she doesn't need an interpreter. My mom doesn't need an interpreter. So we want to, again, make sure that we approach the family member, usually is very worried about who's the interpreter. Is the interpreter going going to maintain confidentiality? And does that mean that we're going to literally, we've heard this from a family member, if the interpreter comes, they will kick me out of the room. And it's like, no, it's going to kick you out of the room. The interpreter's role is not to take the role of the family member, is to be there as an additional member of the healthcare team. So if you say all of those things, I think in the majority of cases, we get a yes. If we're still at a point of conflict, I think definitely calling our office is also an option. We are able to have those conversations sometimes ourselves with the patients and family, and that helps them really understand. So Deanna, our manager of interpreter services, can do that. And then if there is still in the very, very, again, outlier scenario in which there is still a refusal after all of that, we do have a refusal of interpreter form that needs to be signed by the patient and needs to be actually explained to the patient using a qualified interpreter. So we make sure the patient understand that refusal of interpreter form still has a sentence in it that says that even if the patient signs that form, if the physician or any of the members of the medical team requests an interpreter will still be present. So you can go all the way to that.
I wanted to add something, Shiva, if you don't mind.
Sure.
There is something else that we tend to forget when we talk to the family members of the patients, and it's important to remind them that even though they are accompanying the patient to this appointment, there are situations where they won't be able to actually be with the patient. For example, if the patient is going through a procedure, or if they're going through an MRI, there are situations where the patient would have to be by themselves. So having an interpreter with them would actually help. And we normally encourage that. So that's another way of explaining to the family members why it is important to have an interpreter, because they won't be able to be with the patient all the time.
Was that helpful? Right.
Sorry, I'm just getting the mic back now.
Okay.
Yeah, I have had one or two scenarios where I have gotten to that point, even after all those explanations. And so I've just documented as best I could all the efforts we've made. And it's interesting because it's been with a patient who it sometimes has accepted and then other times declined. So it's been a challenge.
Yeah, and again, I think we've had, I'm going to be honest, we've had physicians who, when the patient again has continued to refuse, they've just told the patient, I'm going to have an interpreter because I don't feel like I can provide you the best care. So and then again, depending, as everything is nuanced in the work that we do, depending, what the patient's medical situation is, even giving, the option of the patient to say, for me to continue to be your physician, I'm going to need an interpreter. And if that's not what you want, then I'm not just going to be able to provide you ongoing care that you need, because I don't feel I can do it in a way that is that provides you good care and that makes me feel like you're understanding information. So we've gotten all to that point too. Again, it's definitely, I would say, the outlier situation, but certainly a challenging one.
No, absolutely. Thank you for that, for both of you.
I think we can take
Shiva,
another
it's
question.
Katie again. Just
Thank you.
I've had a couple of situations where an individual knows interpreters, in-person interpreters in our community, and just maybe for providers to be aware that that could be like, maybe not that they don't like that person, but they just don't want their information, even if it's in their interpreter's confidential knowledge. And so in that situation, like if you elicit that that might be contributing, I'm imagining it would be perfectly fine to say we could log on to the interpreter line where we'll get kind of a random national person. That'd be fine, right?
That is, yeah, that would be fine. I think if you just, again, remind it that, I think it's always good to just remind the patient still that, I realize you may know them, but just remember that medical interpreters are part of our medical team, and we'll keep everything confidential. But if you prefer, we can use the remote video interpreter for this visit. But I think just reminding them again that the medical interpreters are bound by confidentiality, I think is important. But yeah, I mean, it is actually, I would say, mostly unusual for our patients not to know the interpreter somehow, because you all know Madison is at the end of the day is a small place. We all kind of somehow connected, and so in our communities, immigrant communities, even more so, right? So not unusual for patients to have known this interpreter or in-person interpreter somehow in the community. We you know, amongst the Spanish interpreter, we always smile about the times of the day in which we do go to stores and don't, because we may run into most of our patients. And so and always being very cognizant of how small of a community it ends up being. So
Hi, Luther Gaston. I thank you for that nice lecture there. Do patients prefer video interpreters or phone interpreters when you have to use the national line? Do you know?
So thank you so much, Luther, for that question. I think most patients prefer video interpreters if it is in a place and where it can stay in place and they can see the video, as opposed to like moving it constantly around. So I would say video if it's it's a time in which it can be a stationary kind of place where the iPad is placed. But if it's something where there is going to be a lot of movement and needs to move, having the phone interpreter on speakerphone is probably best. But generally they prefer video for sure.
Okay.
But they first prefer in person. I should say that too. Like their first preference by far, we hear from our limited English proficient patient, is they prefer generally in-person interpreter. And then after that, video, and third, phone.
Do you know if they have a preference for the same interpreter, if they can have that, or is it, do they, you know, because I have one medical student who she was saying her mom speaks Vietnamese, and so, you know, they get frustrated because every time they have to go explain everything all over again. And so one of the things that she was trying to determine is if it would be better for patients to have a more longitudinal interpreter versus a more intermittent kind of new person every time they go. Do you have any information on that at all?
Yeah, so that's also an issue that comes up frequently. And I would say it would be impossible. So it would be the same as saying that every time you go to the, you know, ER, you would have the same physician, right? We know that's like, it would be not possible for us to get to that level of making sure that the same interpreter follows the same patient all the time. And it's interesting to hear sometimes the feedback about they have to repeat themselves. Well, they would have to, like, it's not because of the interpreter that patients have to repeat themselves. Is because when they go for a visit, usually the way the system works is you get asked questions, often the same questions over and over again. So sometimes people see it as a consequence of the fact that they are limited English proficient and have an interpreter, but really the interpreter is not asking the patient to repeat themselves. Interpreters can jump in the middle. I can tell you, we jump in the middle of conversations with no context all the time. So I think it's back to saying, you know, we can't ensure just operationally that kind of same interpreter for the same patient. We do try for inpatients, for example, try to have the same interpreter scheduled. And then if it's a complex situation like end of life or things that are really conversations that are really delicate, we do try to have consistency of interpreters, but we cannot guarantee it. I know we're out of time and I apologize. I shouldn't be 1 minute over. I know you all have a lot to go to. I really deeply appreciate the time to talk about language access. If there are additional questions, please feel free to contact Diana or myself. And again, we really appreciate the focus on providing good care to our limited English proficient patients. Have a wonderful day.